Hi guys, welcome back to the channel. So let's start today's class. Ameloblastoma at angle of mandible. Consideration and points to keep in mind. Is it an extreme ameloblastoma or recurrent ameloblastoma? Was enucleation curettage attempted before or not? Okay, these are the things we should look for first. Okay, या क्या वो एक्सट्रीम या फिर रिकरेंट अमीलोब्लास्टोमा है या यून्यूक्लिएशन एंड क्यूरेटाज प्रोसीजर पहले हो चुका है, इट इज़ हैज़ बीन अटेम्प्टेड और नॉट. Okay, then old radiographs and patient pictures would be of help. Obviously, size of tumor, it dictates the mode of treatment. Facial aesthetic and facial deformity. Facial aesthetic and facial deformity mainly when maxillary tumor is concerned, also in mandibular tumor but mainly in maxillary tumor. Okay, age of the patient, mostly peripheral resection to be performed to prevent pathological fracture. We have seen last class how pathological fracture had been prevented. When the age of the patient is more, we give a curvilinear incision or curvilinear shaped thing or U-shaped thing rather than giving a box type with the right angle corner. Okay. Now, histopathological diagnosis to identify the invasion or nature of the ameloblastoma to further dictate the treatment protocol. Okay, according to histopathological diagnosis, we will go for the treatment plan. If it in histopath, we can also see if it is mural, transmural, intramural invasion, non-invasive, everything we should see. We can know if it is unicystic or not, if it is solid, whatever it is, we can see in histopathological diagnosis, and accordingly we can go for our treatment or we can follow a treatment protocol. Now, radiograph. CT scan is a gold standard to understand the bony destruction and understanding the anatomical barrier. Okay, CT scan, obviously for the anatomic boundaries we should go for CT scan and to understand how much destruction is there. Okay, margin, reconstruction and resection, obviously if only limited to angles, condyles are spared, peripheral resection to be advocated, further bony involvement is noted, continuity resection is done. Okay, if it is only limited to angle, then we should not involve the condyle, condyles are spared, peripheral resection करना चाहिए, peripheral resection to be advocated. Now, if we see a further bony involvement, then continuity resection is done. Reconstruction using autogenous graft or recon plate depends on the defect. Either we can go for autogenous graft or we can go for recon plate. ठीक है, like this. Okay, this is the defect we can see and give to avoid the pathological fracture. Then there is the placement of 4 bicortical screws. Okay, now placement of bicortical screws on each segment is done. However, 2 or 3 bicortical screws on proximal segment consisting only the condylar neck. Okay, यहाँ पे 2 या 3 ही लगेंगे. When condyle extirpation is done, a recon plate with condylar replacement is used. अगर condyle भी हटा रहे तो we can use a recon plate with condylar replacement. Absence of condylar segment, metal condylar segment have long-term functional success without complication if they articulate against native disc or against reconstructed soft tissue or cartilage. Okay, metal condylar segment have long-term functional success. Placement of metal condyle directly against the bone invites bony erosion, pain, bony reaction and fibrosis. Okay, it has a disadvantage as it invites bony erosion, pain, body reaction and fibrosis. Use of allogenic cartilage, derma or dermis is acceptable in tumor patient. In these cases, 5 to 6 bicortical screws must be placed in distal segment to gain sufficient stability. Obviously, 5 to 6 bicortical screws should be placed in distal segment. If pre-op CT scan indicates a tumor confined within cortices, no perforation, then the cortex of mandible becomes the anatomic barrier, and subperiosteal dissection proceeds. If perforation noted, then supraperiosteal dissection, then periosteum becomes the anatomical barrier. Okay, it's saying if there is no perforation, if there is no perforation, the cortex of the mandible becomes the anatomic barrier. Okay, the cortex of the mandible become the anatomic barrier and subperiosteal dissection is done. And if perforation is there, then supraperiosteal dissection is done and periosteum become the anatomic barrier. In either case, local excision of next anatomic layer and frozen section is given. Now prognosis. Ameloblastoma treated by resection seldom occur. 98% cure rate. Enucleation and curettage procedure are associated with a high incidence of recurrence. Concern of malignant ameloblastoma is always present if recurrence develop. Okay, that's all for today. Next class will be dealing with bone graft substitute and starting with the new tumor. Till then, like, share, subscribe and comment. Bye.